Thank you. So for those who are tuning in to the recording, my name's Adam Kinney. I'm the chair of the Health Services Research Networking Group. And this is the first session of what we're calling the HSR Methods Hub. So it's a showcase of cutting edge research methods aimed at advancing rehab relevant health services research, and have a really exciting talk. But before we get to introducing our speakers today, just have a few housekeeping items. So this is put on by the Health Services Research Networking Group. So we're always looking for new members. So if you're interested, please email me there at adam.kinney@va.gov, and we'd love to discuss potential collaborations with you. Also, just want to note that Health Services Research Networking Group is just one of many in ACRM. So if you're not already a member, I would highly encourage you to join. Also encourage you to join the ACRM spring meeting, April 18th to 20th, and the annual conference in Dallas, which is still looking for proposals. So if you have any work, please feel free to submit that. Also, please submit that work to archives in the open access Archives of Rehab Research and Clinical Translation. And just another thanks for being here. And with that, I will let Drs. Moroz and Brzezinski to share their slides, and I'll do a quick introduction.
Sure.
So our speakers today are Dr. Tracy Moroz and Dr. Rachel Brzezinski, speaking on the applications of methods for policy analysis in post-acute care. Dr. Moroz is a health services researcher whose research agenda focuses on the impact of policy and delivery systems on access to and quality of post-acute care, with a focus on home health and care provided in rural communities. She received her Master of Science in OT from Boston University and her PhD in Health Services Research and Policy from Johns Hopkins University. She's a co-director of the Advancing Health Services and Policy in Rehab, or ASPIRE lab, a multidisciplinary lab within the Department of Rehab Medicine, and is an investigator with the WWAMI Rural Health Research Center and the UW Center for Health Workforce Studies. Her research has been funded by the NIH, AHRQ, and the Health Resources and Services Administration. Dr. Brzezinski is a physical therapist with a clinical focus on complex geriatric and neurologic populations, and health services researcher whose work emphasizes relationships between health policy, care delivery, and patient outcomes in post-acute care, especially skilled nursing facilities. She received her doctorate in physical therapy from the University of Puget Sound and her PhD in rehab science from the University of Washington. She also co-directs the ASPIRE lab at the University of Washington and is an investigator with the UW Center for Health Workforce Studies. Her work's been funded by the Foundation for Physical Therapy Research, NIH, and the Health Resources and Services Administration. So just want to thank Drs. Moroz and Brzezinski for being here. Genuinely can't think of a better way to kick off this webinar series than showcasing this work. So thank you all for being here, and I'll let you take it away.
Well, thank you so much for that very kind introduction, Adam. We are super excited to be here to talk about some common methods for policy analysis and share examples from our own work in post-acute care. You can go to the next slide. So as noted, Rachel and I co-direct the UW ASPIRE lab. When we say we're multidisciplinary, we mean it. Rachel's a PT, I'm an OT. Our doc students include a speech language pathologist, newly a prosthetist and orthosist, an MPH. We've had postdocs that have backgrounds as health economists, psychologists, nursing, public health practitioners. And we collaborate with lots of folks, in addition to other therapists, with physicians, economists, medical geographers, biostatisticians, and more. So We're excited to talk to you about a couple of examples of what we've done in terms of policy analysis and particularly around the rehab space. So you can find out more on our website, but we'll go ahead and jump right into the presentation. So next slide. So by the end of the session today, we're hoping that you'll be able to define differences and interrupted time series methodologies and describe the assumptions for each of these methods. We want you to be able to interpret the results of these methodologies using some examples from our studies, and also compare and contrast challenges in reporting and interpreting results. As we know, if our audience doesn't understand what we're doing, it's not really helpful in moving research and the literature forward. Okay, next slide. So just quickly, an overview of policy analysis. We want to make it clear that policy analysis is not limited to the types of examples that we'll be discussing today. It can focus on development of policies, how they're implemented, including barriers and facilitators, implementation fidelity, as well as the evaluation of both intended effects or unintended consequences of policies. So methods for policy analysis, they have been developed and utilized across many different disciplines, not just health services research. You can find examples in economics, public policy, social policy, education, environmental health, just to name a few. These methods are numerous, including quantitative, qualitative, and mixed methods approaches. We certainly can't cover the entire scope of methods for policy analysis in this intro session. So we're going to focus on two very commonly used quasi-experimental methods, difference in differences, also known as DID or DID with a lowercase I, or diff and diff, depending on to whom you're speaking, and interrupted time series. We want to make it very clear that methods are always evolving. So we're going to touch on some variations and extensions of sort of the basic models of D&D and ITS, but know that you're going to want to stay informed about new methods as they continue to develop. So next slide. Okay, so I'm going to start with D&D or differences and differences, and then Rachel's going to talk about ITS. You can go on to the next slide. Okay. So here's our overview of what DID is. So again, it's a quasi-experimental approach, and it's used to understand the effect of a treatment when a controlled trial is not appropriate, right? This is super common in policy analysis because, often we can't do randomized control type trials or those sorts of approaches. They're not practical, they're not ethical for policy studies, but we do want to make it clear that you can use a diff and diff approach to study other types of interventions, treatments, et cetera, but we're going to focus on policy. DID can use either longitudinal data when you have the same subjects across time, or you can use repeated cross-sectional data. Your standard DID model is going to have two groups, a treatment group and a control group, and two time periods, before and after the treatment, or in our case, when the policy is implemented. It's called difference in differences because what the method does is it allows us to compare the difference between the difference in outcomes before and after a policy is implemented, comparing the treatment versus the control group. So I'm going to show you the standard equation and talk you through that quickly, but then we'll look at a graphical depiction, which I think makes it a little easier to understand. So your B naught here, this is this sort of standard simplified equation for diff and diff. The B naught is your average baseline outcome. The B1 is going to be your coefficient for the time trend in the control group. B2, the difference between the treatment and the control group before the policy is implemented. So that's our policy term. And then B3 is going to be modeled using the interaction between time and policy. And this is the one that represents the difference in differences between the treatment and control group over time. So you can also include, you can also include covariates as fixed effects. That's why I have a B4, but we'll kind of skip that to get to the main pieces. So let's go ahead and go to the next slide to look at this graphical depiction. So here, just to orient you to what we're seeing, the x-axis is going to be time. The y-axis is going to be your outcome. The green vertical line indicates when the policy is implemented. Here you see the orange line is our control group, and the blue line is the treatment group. And you can see how the slope of the blue line increases or bends up following policy implementation. And that gray dotted line represents sort of the continuation of what we'd expect to have happened in that treatment group if the policy had not been enacted. So again, here it helps to kind of understand these coefficients a little bit more easily when we see the picture. B1 is going to represent that time trend or change over time that we see in the control group, whereas B2 is going to represent that pre-policy difference and the outcome between the treatment and the control group. B3 then again is our diff and diff. That's our diff and diff estimator. That's going to be that difference between the change we expect based on that pre-policy trend if it continued and the actual difference following policy implementation. So basically the D&D approach allows you to subtract out the time trend that's experienced by the control group, serving as like a counterfactual to the treatment group. Okay, next slide. So one of the things that makes difference and differences really useful is that it's relatively easy to explain and interpret. You just need a policy that happens at one time. You need a treatment group and a control group, and then you can explain how those outcomes vary. It also allows for differences in the starting level of the outcome between the treatment and control groups, so they don't have to start at the same place. A key advantage of a difference in difference approach compared to a more simplified pre-post design is that it does allow for a time trend in outcomes separate from that policy, right? So as long as those same trends are experienced by both groups in the baseline period, you can account for a different change over time separate from the policy. You can also use very different types of specifications, including mixed effects, to account for the fact that you have repeated measures. But so that's a simple explanation. But there's some really key assumptions that have to be considered about whether or not the diff and diff approach is going to be appropriate for your analysis. The one you hear about most is the parallel trends assumption. And this means that you have to have the same trends experienced by the treatment group and the control group in that baseline pre-policy timeframe. So I'll give you a couple examples of how we might test for this when I go over the examples. We also have to have a relatively stable and treatment and control group over time. Since we can have repeated cross-sectional data, that doesn't mean that we have to have the same subjects over time. It doesn't have to be longitudinal, but we can't have major changes in either the size of the treatment group or the control group or the composition of these groups related to the policy or otherwise. Third, you can't use diff and diff to study a treatment that's related to the outcome at baseline. So for example, if we wanted to study moratorium policies and what the impact of moratorium policies is on the healthcare market, well, we can't use the standard difference in difference approach because the moratorium policy itself is put into place because of the healthcare market, right? So you have to have unrelated outcome and baseline with the policy. And then finally, you can't have spillover effects between the treatment and the control group because you're using that control group as your counterfactual for the treatment group. You have to have a policy that is not anticipated to have spillover effects. So let's walk through some examples. Next slide, thank you. So first, this is a study on the home health value-based purchasing purchasing demonstration program, which was led by one of my former postdocs. The HHVBP, the goal is to incentivize high quality, efficient care by either rewarding or penalizing home health agencies based on their performance compared to their peers. This demonstration was launched in 9 states in 2016. All home health agencies within these 9 states were mandated to participate, so there was no opt-out. And this right here should be just stinging alarm bells of like, hey, difference and differences, this could work. So we have a group of treated, being the agencies in participating states, and control agencies in states that were not participating. We also have a total performance score that's used in the HHVBP demo that uses really similar measures as the publicly reported 5-star ratings on Home Health Compare. So we have a nice data source for an outcome quality that we can look at. So this is why we employed a difference in difference approach here to see if HHVBP increased the quality of home health agencies. So our policy, HHVBP, we have a clear implementation time. It happened at the same time for all 9 states in the demo. Our control are these agencies in states not participating, our treatment agency in states that are participating, and our outcome on this particular slide is the quality of patient care star rating. And that's based on measures derived from both claims and assessment data. So if you look at the figure here, you can see before the policy was implemented, before that big vertical line on the figure, you see generally parallel trends in quality. And then you see after the policy was implemented, you see a relatively flat control group, those non-VBP agencies, in terms of their quality changes over time, but you see an uptick, that change in slope after the policy for the HHVBP. And I've added the little beta coefficient there for the policy times time interaction, just to give you a sense. That's what we're measuring. That's the difference in difference. So what we end up seeing here then is we do see that there is a change where we actually found a 0.09 increase in quality star rating attributed to HHVBP, right? Whether or not we think that is a really significant change is another story, but we do see an increase. Okay, next slide, please. So this is also still the HHVBP program, but this figure you're looking at is a change from our outcome from the patient quality of care star rating to the patient experience star rating. So this is the survey data from the home health CAHPS that goes to inform this 5-star rating. So here you can see that we have, well, you can see here there's some similarities pre-policy. So there is actually, and we did some testing, that the trends are considered similar enough, but visual inspection is one of the ways that people look at it. And you see some differences in the post-policy time period, but there's not a significant difference. And that's why you see I'm not actually trying to measure the difference between the dotted line and the solid line, the VBP and the non-VBP. There is just a teeny tiny little coefficient, beta 3, that is not significant for here. So let's go ahead and go to the next one. Next slide, please. Okay, so this example is from a study that I worked on with a doctoral student on rural add-on payments for home health. So clearly, I'm a home health researcher. So what rural add-on payments are, it's a percentage increase in what the standard payment amount would be for a home health agency for serving a beneficiary that lives in a rural community. So briefly, this study takes advantage of the fact that the rural add-on payments have turned on and off over time. And there was a period before the Affordable Care Act where they were off. So a 0% no rural add-on payment in effect. And then it started in April of 2010 at 3%. So this is the rural, again, 3% percentage-based increase of all payments going to agencies for serving rural beneficiaries. So here we took the exact same approach. We've got our policy, the add-on payment, our outcomes here. We actually looked at 2 different outcomes, 30-day rehospitalization rates and 60-day rehospitalization rates for patients who entered home health directly after an acute hospitalization. Here, if you look at the figures, so the figure on the left is going to be your 30-day hospitalizations. The figure on your right is going to be your 60 days. So I like this example because you can see it's not always just the clear sort of difference in difference sample plot that you see where there's 2 very easy to follow lines. So here we see some seasonal variation very much in what these discharge rates look like. So what I want you to notice, though, is that you look prior to the policy, the treatment and the control groups, so the rural versus the urban beneficiaries, they're very, very close, very, very close to each other. And you start to see some separation between those 2 lines, even though they're following the same seasonal patterns over time. So that's where we start to see an effect graphically, just looking at as the plot of these, and these are unadjusted rates. Okay, and how we test this parallel trends assumption, I wanted to share a little bit more about that. You can do a visual inspection of the plot, but we like to be a little bit more rigorous than that too. So one of the ways that we can test for the parallel trends assumption is to do a placebo test. And this is where what we do is we actually run the same regressions, but we run them in the pre-period only, and we implement different fake treatment dates. So we'll say, here's a fake implementation of a policy date. And when we do that with our same model, with the same time and policy interaction, we expect that time policy interaction term, that beta 3, we expect it not to be significant. Okay, so that will tell us that the trends in the pre-period are the same. So that is an example of how we can test for parallel trends. You can go to the next slide, please. Okay, so what did we actually find? What is the result here? Well, here we see that we actually found no significant differences in that rehospitalization between rural and urban home health agencies prior to policy implementation. And if you look at the table, that's your rural, that very first row of results, no significant differences there. Then we see that we actually do have a significantly lower rehospitalization in the post-policy period for both those rural and the urban agencies. So that's the second line of results, that post-policy, right? So that's our policy indicator. And then what we see for our beta 3, which I pointed out, that's our diff and diff, that gives us the fact that we have within rural agencies an even greater reduction in rehospitalization rates for rural compared to urban agencies post-policy. So that's our diff and diff. Again, these are this is a logistic regression. So these are margins. We're presenting the margins, which then represent percentage point differences in rehospitalization rates. So are these huge changes? Maybe not. And if you actually do the math on the percentage that these percentage points actually come out to be, it's about 3%. So you pay about 3% more and you get about a 3% reduction in your rehospitalizations. So there's a lot of discussion about whether or not that's enough to make it work, but I'm going to stick to the methods and not get into the editorializing about whether or not these are of value. So we'll head to the next slide, please. So I've presented some examples that are fairly standard diff and diff models. Both of the examples I presented, we did control for other covariates. We used random effect specifications to account for some correlations over time. So they're not quite as simple as what I presented, but the movement around diff and diff, it's getting even more flexible in terms of how different models are approaching. So for example, and I'll say we have a set of references for you at the end of the slides so you can get more information, but I just want to talk to you about some of the extensions that are moving out there in the diff and diff space. So first of all, there's a recognition that many different types of policies, there are impacts over multiple time periods, or there's variation in the timing of when policies are implemented. So Callaway and Santana are two biostatisticians that are doing work on approaches to account for staggered policy adoption. And they often give the example of medical marijuana laws and how that implemented in different states at different times, as well as approaches when you have more than 2 time periods that you want to look at. So not just a pre and a post, but more time periods than that. There are others that are doing this work as well. I mentioned Callaway Santana because they have a lot of free information out there on GitHub about how you can model these in various different statistical programs. And Stata, if you're a Stata user, actually has some of their methods in their latest version. So they're not the only way to go, but they're doing a lot of work in the multiple time period or staggered policy adoption diff and diff space. There's also a recognition that policy effects can be time varying. Oftentimes, especially if a federal policy is announced, there might be anticipatory effects that happen in advance of the actual policy implementation, as well as changes in how the policy effects affect outcomes over time as people get better at adapting to a policy, for example. So there's more work being done in those spaces to be able to look at lags and times and see how that looks. Time-varying confounders are also a potential issue. And there are ways to one of the ways to look at that is to use triple differences by adding an additional comparison group. That way you can sort of subtract out the differences both in the time-varied confounders as well as from the control group if you choose your additional comparison group wisely. Or you can use propensity score-based difference in difference models to look at that as well. The last one I want to mention is a universal difference in difference approach, and this is also out there to tackle using other probability modeling when the parallel trends assumption becomes problematic with your data. So they're becoming much more flexible over time. And my little last note here, ask your friendly biostatistician for help as needed. The farther I get from my training, the more I realize I'm getting farther and farther behind the time. So I stick with the biostatisticians. I always have one ready to help out with the team, and they're really an important member of the team to keep you going and keep you up to date with the latest policy methods. And I will turn it over to Rachel.
Great, thanks, Tracy. I'll second triple the biostatistician shout out. And when we go through some of our examples, I'm going to actually highlight where my expertise and a direct interaction with the data ended and where we brought in a biostatistician, because I think that can be really helpful for clinical people with clinical backgrounds and even HSR backgrounds to kind of know what sort of considerations to make, and and kind of when other people have decided it may be a little bit too much without a biostatistician support. So I'm going to talk about interrupted time series, and this, I'm realizing how similar this plot actually looks to the difference in difference approach that Tracy talked about, and that's in part because it's really the same questions. You use an interrupted time series for a similar question as the DID, and did a policy change or a policy impact an outcome? And it's also a quasi-experimental approach. But there's a few kind of major differences, and I'll talk through the basic process of ITS here, and then we can talk more about the kind of assumptions and considerations on the next slide. But what happens in a basic interrupted time series is, again, on this plot, but you do create two comparison groups, but for ITS, your comparison group or counterfactual is created when you extend a pre-interruption baseline trend for the same group. So to break it down a little bit more, the process of ITS involves modeling a linear trend in your outcome in a baseline period, so before a policy occurred. And then you extend the pre-interruption trend into the post-interruption period, and that trend becomes the counterfactual. So you end up with two estimates. And like DID, for your policy effect, you end up with a level change, which is this kind of just what it looks like, the change in the level of your outcome at the time of the policy interruption, and you get to choose the time period based on kind of your knowledge of the policies, whether it's the first week of the policy or the first month or the first quarter, and that level change will reflect that immediate policy effect. And then your second estimate is the change in trend. So it's more of a long-term policy effect, but it's estimating the difference compared to that counterfactual baseline trend. So that's the basic concept, but there's kind of pretty important assumptions and considerations. And the first two I've highlighted. So these are really the reasons to choose an ITS approach over a difference in difference approach. And the primary reason is because you don't have a good control group. And so, as Tracy mentioned, the control group is essential in a DID, and in certain policy applications, that's not practical. And that's really the situation we've been in with a post-acute care policy that I'll talk about in our examples that was applied to every skilled nursing facility at the same time around the country. So there really wasn't a good control group option. And it's the second, but well, I'll talk about this too, but the control group is a plus. So there is actually an option to do an ITS with a control group as well. That makes it a little bit more robust, but it's not necessary. When you do have a controlled ITS, it doesn't assume parallel trends at baseline. So that's another really nice bonus for ITS, that kind of beyond difference in differences, you don't have to make that parallel trends assumption, which is one of the most important for the validity of a DID method. Another consideration, it's easier to model an ITS if you have a policy that was implemented at one time rather than that staggered approach that Tracy mentioned. It is possible, but much trickier if you have a staggered approach or a staggered introduction of the policy. ITS is also best if you assume or anticipate a quick response. Again, there are ways to model for a potential lagged effect of a policy, but it gets a little bit more complicated and is better if you have a control group. It's also important to have an adequate number of time points. So an ITS, the literature varies a little bit, but they want you to have at least 6 to 8. 8 is better, more is better, of observations over time in both the pre and post policy intervention period. And that's for power, and that's also because if you're really comparing a baseline trend, it's a trend, not just a level. So a trend of 2 months or something may or may not be a valid trend. In ITS, you can easily adjust for both constant and time varying confounders. So that is another benefit that gets a little bit trickier in DID. But the major drawback that we'll see when I try to explain a few of our examples is it can be really complicated to interpret an ITS analysis. because you have those two estimates every time you have an interruption. And then if you decide to do more interruptions or control group, the interpretation can get pretty onerous pretty quickly. It is always important to visualize your data for a couple of reasons. The first is to make sure you do have a linear baseline trend. As Tracy mentioned, seasonality is a really big challenge in any sort of longitudinal analysis. So making sure to account for that. It's fairly simple. We usually will do a quarterly or a monthly just fixed effect. And I'll talk a little bit about how we've done seasonality adjustments in some of our other work. And then finally, you also want to see if there are other big shifts in your data that you weren't anticipating. So you will establish your policy interruptions a priori, but it may be that there's something else happening that you didn't anticipate that plays out. And there's a change in your trend that you want to account for, and that might require an additional interruption. Okay, so I have a couple examples. I don't want to take up too much time, so I'll probably start with the first two, and they kind of go from simple to complex. And then there's a final controlled ITS that has lagged time periods that, full disclosure, was a huge effort of our biostatistician, so that's in there. But these first two examples I can kind of walk through and shows kind of what the method is all about. So this first study was in response to the patient-driven payment model, or PDPM, and we wanted to look at how staffing levels for physical and occupational therapists and assistants changed after this policy, which, as most folks I think here know, the whole point of PDPM was it suddenly disincentivized this high volume therapy provision. So we anticipated some pretty significant impacts on staffing. So for this first paper, we had multiple outcomes, but this plot is just for total staffing minutes per patient day for PTs, OTs, and their assistants in all US SNFs. We got to use weeks as our time period. And even with that short of an interruption, we still saw some pretty immediate effects. So that was kind of interesting to see, not necessarily cool if you think about how it was staffing declines for a lot of folks around the country. This is the model we used. I'm not going to walk through every coefficient, but it is in the paper. And it's actually fairly simple because we only have one interruption. But you can estimate the level change here, which I've kind of colored in purple. I've crudely extended our pre-PDPM baseline trend here in green as the counterfactual. But just looking at the level change that immediate week after PDPM, we found about a 5.5% decline in PT and OT staffing compared to our baseline, where our baseline trend would have ended up at that point in that week. And then we found an additional 0.2% decline in staffing per week after policy implementation. So you can see that this line, the slope is is declining a lot more rapidly. We also included not necessarily a common seasonality effect, but because we had weeks as our time point, we ended up including a fixed effect for a holiday week, because that's what we were seeing with all these little drops in major US staffing during holidays ahead of time. So we did account for that. So that's a pretty basic example. One interruption we had, and then for interpretation, you interpret both the level and the trend change. But over time, you can also kind of add that up. So that is the sort of at the researcher's discretion is, adding a level change in 1 week and then multiplying the trend change out by how many weeks you had. We came up with about a 15% total decline by the end of March of 2020 in therapist staffing. So this second analysis is similar. We wanted to mostly just kind of extend our time period and did a little bit more robust analysis. And the goal of this second analysis was also to look at variability in this staffing response after PDPM, which we did, but it gets pretty complicated pretty quickly. So I'm just going to kind of look at our kind of primary analysis here. But what you'll see here is 3 interruptions in the vertical lines. The first is PDPM, similar to our last study. And then the second, we wanted to see how the beginning of the COVID pandemic would impact therapist staffing and SNFs. When we plotted our data, that's when we decided to add this third interruption, because we saw this huge reversal in staffing trends, which actually kind of started when vaccines started to become effective, and census started to pick up, because this is a per patient day measure of staffing, so it's census adjusted. So this kind of reversal corresponded with once SNF census started to recover during vaccination efforts. So that caused us to need to estimate a lot of different coefficients in the model. This equation is mostly just to demonstrate how quickly these analyses get complicated, and this is where the biostatistician definitely came in to make sure we interpreted everything correctly. This equation is actually from our secondary analyses, where we were looking at variability in these changes based on different facility characteristics. So those are the bold coefficients, but even when you don't add those bold coefficients, it gets pretty tricky pretty quick. We included week of year fixed effects for seasonality for this one. And we also adjusted for time varying weekly COVID case rates, which is a nice feature of ITS that you can use that time varying covariate. And then, as Tracy mentioned, we used a mixed effects model, so random intercepts for facilities to kind of account for those repeated measures over time. So to interpret this, the way that we wrote these models, we ended up at each interruption kind of creating a new counterfactual. So the baseline trend shifted to being the trend in the previous time period for every comparison. So when we were looking at the PDPM effect here, we were comparing it to just the pre-PDPM baseline. When we were looking at the COVID effect, we were comparing it to just the after PDPM before COVID baseline. And what we found was that PDPM was associated with an immediate about 6.5% decline in therapist staffing, a more negative trend up until the COVID pandemic hit, when we saw another small decline in the immediate change or staffing in the week of March when COVID kind of started. But we started to see a recovery. So the trend did reverse, and that's when you'll see a positive 0.42% per week difference compared to this kind of period 2 trend. And that is primarily because staffing had also declined so much. So there was maybe, SNFs hitting a floor effect where they couldn't stop staffing so many therapists when per patient, if that makes sense. There wasn't much of a immediate difference as these vaccines started to improve, but then we wanted to model how much the trend declined again in staffing per patient day as the census denominator started to increase. So that is kind of 2 somewhat complicated ones. I know we have we want to have a little bit of time for questions, but I have a couple of slides just showing what a controlled ITS looks like. And we do have one publication that we used a controlled interrupted time series approach when we did have a good control group, when we wanted to look at outcomes that were short stay quality outcomes before and after skilled nursing facilities changed ownership. So we were able to we didn't want to assume parallel trends, which is why we didn't use a DID. And in fact, we found that they weren't parallel when we did our analysis. So that's why we used a controlled ITS approach. But similar to a DID, we did look at differences in 3 short stay patient outcomes before and after a skilled nursing facility changed ownership compared to skilled nursing facilities that did not change ownership. So that paper is also out in JAMA Network Open. Because it's a controlled ITS with multiple time periods, there's not a pretty graph that makes that one easier. But you can look up the reference if you'd like. So we'll just to summarize, these are kind of the major pros and cons for each of the methods. They're both robust quasi-experimental approaches DID is easier to interpret, but it does require a control group and assumes parallel baseline trends in your outcome. ITS is a little bit trickier to interpret. It doesn't require a control group, but that's an option. It does require a linear baseline trend that doesn't have to be parallel if using a control group. So overall, again, we'll reiterate, this is not a decision we take lightly when we think about analyses. It's always nice if you can run it by a biostatistician, but they are both publishable and solid methods for looking at policy analysis. And then, of course, if you have different time periods of when policies are implemented, it complicates things, but both there's emerging methods for doing differences and ITS in that situation. So there's a lot of fun papers that we've included in these slides, and I think Adam has a copy, so he's able to share that. And with that, we'll acknowledge some of our funders. The HVBP project was funded by NIDLR. The Rural Add-on Payment Project was funded by AHRQ, and our ITS studies are funded by the NIA. I think I'm going to stop sharing so we can take some questions.
Thank you so much. That was really, really interesting. I know I put this in the chat, but if you all have questions, please enter them in the chat and I'll read them. And so some are coming in. So one question from Megan. Great presentation. Have you been able to see how these policies affect SLPs?
Thank you so much for that question, Megan. We are so thrilled to have an SLP on our team now, and we will be including SLP in all of our future work. So we're actually starting to look at patient level changes, both for PDPM in SNF and PDGM in home health. And we're looking at therapy provision across all the disciplines, not just PT and OT.
Yeah, I think I'll second that. The development of PDPM was kind of different for PT, OT, and speech, and there's been other work that showed, some decline in speech staffing after PDPM, but definitely not as much as for PT and OT. So that is sort of why we initially didn't include it. But yeah, our speech therapy trainee would definitely be like, doesn't matter, you still want to add it in. So we are certainly including those in future work.
And Hillary asked, is anyone starting to look at staff level responses to policies, increase burnout, etc.?
Yes.
You want to take that one or should I, Rachel? Yes. So we're not the only ones looking at it, but part of the NIA grant that we have that has funded the staffing ITS studies that we presented is also funding, it's a mixed method grant. And we have a collaborator in Pittsburgh, Natalie Leland, who is running the qualitative side of that study. We have both administrator and staff level interviews to understand what their experience, both in the SNF world and in the home health world, for those policy changes, and then through the COVID pandemic. So more to come. We're hoping some of those are going to start to come up soon. We have some under review now.
I can answer Cynthia's about if the control group doesn't have parallel baseline trends. Yes, that is why we used controlled ITS and we did not use a DID because a controlled ITS doesn't require. I know the short little picture I had for controlled ITS did have parallel baseline trends, but that's not a requirement. And in fact, when we a priori decided not to use DID for our question, because we were looking at how short stay outcomes changed after a skilled nursing facility changed ownership. And we assumed that nursing facilities that did have an ownership change would probably have worse baseline quality. That was just an assumption. So that because we wanted to make that assumption, we went with a controlled ITS instead of a DID.
And I would say despite DID being generally easier to interpret, I would say when you get into those extensions of DID that do the extra modeling to try to control for non-parallel trends, the ITS actually makes more sense. I think it's easier for people to understand. So yeah.
And Brian asks, for policy studies where you're comparing pilot and non-pilot states, for example, nursing home compare, how do you decide on what states to include as controls?
So that's a great question. One, you can look for similarities in states. I mean, there's certainly different approaches to making sure you have states that are as similar as possible to move forward. I can tell you with our HHVBP study, the reason why we included the states that were randomly selected to participate in HHVBP were done so as part of groupings of states that were very similar in terms of home health utilization. So it enabled us to feel confident about how we included those 9 states and then the rest of the states that were part of the regions that were created, which were mostly geographic, but not exactly, to account for similarities in provision within the states. So certainly when you're choosing controls, you don't want to choose a control that doesn't make any sense. But for these policy options, if looking at things like similar utilization or similar quality can be helpful ahead of time.
And then there's also the option to use everyone as a control, everyone that you have data on, and then adjust for certain covariates. So in our ITS, our controlled ITS, we did a lot of different, controlling for nursing home ownership, controlling for, for profit status, for case mix, for, kind of a bunch of other things in case. So to make sure that not only do you have a control group, but you're kind of adjusting for potential differences between those groups.
And Hillary asks, how are researchers looking at clinically significant changes, for the better or for the worse?
This is also a great question, Hillary, because sometimes, we do modeling with large data sets. So we often find things that are statistically significant, but then there's the debate about whether or not they're actually clinically meaningful. And even in some of the examples I gave today, is a 0.1 increase in your star rating on a 1 to 5 basis, does it matter? Does a 3% overall or a less than 1 percentage point difference in rehospitalizations matter? One of the things that we do in the policy world to talk about what's actually significant is we do the kind of back of the envelope math to calculate what that means in a large population. So a 3% decrease in hospitalizations may not seem large, but across the Medicare beneficiary population, that's huge. So it's really about coming up with when the policymakers, it's often the dollar amount that makes sense, right? And how that's going to impact the payers. And then in terms of clinically significant, it's about knowing what your outcome measure is. And this is the benefit of being therapists who do this work. If you're measuring changes in mobility or self-care, being able to look at the research to see what is a meaningful difference in improvement in either of those areas, for example.
Mm-hmm.
I had a question. It seems, especially when we're talking about national policies, and correct me if I'm wrong, but it seems that there could be some variability in the extent to which those policies are implemented or the ways that they are implemented and potential fidelity to those initiatives. I guess I would ask, does that play a role in any of these results? And if so, are there ways to account for that in these analyses with the data that we have available, or is that just kind of impossible?
I think it totally depends on the policy itself. The benefit of the ones that we've studied is it's a Medicare reimbursement policy that is, the same in terms of like the dollar amount and the same different changes in incentives. But we are, so for these policies, not as necessarily worried about the different impact, but we are aware of changes in, we're starting to look at things like changes in how facilities code to respond to these policies and how that's different, because we know that drives how the policies are reimbursed. So that's not to say that we don't have kind of a fidelity kind of question in mind, but when you're, by virtue of just being this policy is about what SNFs get paid, there's a little bit less wiggle room. But Tracy, I don't know if you have a...
Yeah. Well, I would say on the flip side of that is also then what do we think about when we're including confounders, right? So and the ITS, the second one with the multiple interruptions that Rachel presented, she just presented the primary analysis. Part of why we did that was to look at if there's a different type of response based on profit status, for example. The home health value-based purchasing one, our confounders include ownership, profit status, right? As well as like what percentage of duals are you caring for? You know, are you urban or rural? Like what region are you in, right? So we include a lot of those confounders too, partly because of the idea that we know that the response, even if the intervention itself is one intervention that cannot be changed, the response to that may vary. So that's part of the rationale for, we present the simplified models, but there's a lot of other controls included.
Thank you.
Those are great questions. Thanks everyone for coming to our first webinar.
Yeah. Well, thank you for sharing your expertise. Again, that was really, really interesting. Yeah, just echo what Rachel said. Thank you all for attending. So this recording will be available within 24 to 48 hours. Please, I know Tracy and Rachel said they didn't want to watch themselves on YouTube, so they won't watch it, but all of you, please spread widely and spread the word about this webinar, so we can keep having great attendance in future webinar sessions. Thank you all so much.
Thank you.